Okay. Good morning, everyone. My name is Raphael Asano. I'm professor of the University of Washington and member of the faculty group of the Institute for Health Metrics and Evaluation. It is a great honor for me to participate as moderator of this session of Epitransition in this important event. I would like to thank the organizers for inviting me to share some ideas and giving me the responsibility to conduct this elected audience for the next 75 minutes. We usually like to talk and write about time, anecdotically, scientifically, or as a part of science fiction literature. Time is not a renewable resource. It's an independent variable for time series analysis. It's a key variable for understanding progress and how countries are performing historically. Time represents money for some people and something else for others. Time is an excited subject, but if we are not asked to answer how to define time, we all know what it is. But if we try to define, it will become entangled and in complex paradox. In fact, since we are celebrating 2 decades of the first publication in Lancet about GBD, we are giving high importance to time. However, for those that know how long take any publication in that journal and the preparation of the paper, of course, you can understand easily that the beginning of the GBD era was at least 5 years before the publication or even more. I'm part of that cohort. I started my GBD way of thinking 24 years ago. I have applied that way of thinking in my professional career as an international or national civil servant, or when I'm teaching the new generation of researchers or public health practitioners. I always try to keep in mind and share the ideas of collaboration, innovation, and passion. I'm glad to be here with so many people engaged in the global burden of disease. Coming back to the middle 90s, I didn't realize how far the GBD story could go. Now I'm sure that dreams, big projects, and ambitious ideas can become part of the reality. As I said before, we like to think on time. And again, that is one of the main variables to take in consideration when we speak about the epidemiological transition. The seminal contribution of Abel Ombram from the early 70s helped us to understand that the epidemiological transition is a theory of the epidemiological population change. In that paper, he presented time series for more than 50 years, or even more years for some countries. Please don't forget that he did that publication by hand. I mean, without the current technology, even more merits to recognize. It is important to highlight the influence of this paper in the academic and the political communities. Almost half a century ago, we knew about the growing of non-communicable diseases and the transcendent changes in the epidemiological profiles in some countries. Today, we cannot be surprised that NCDs become an epidemic or high prevalence for some risk factors and population growth are the key drivers of change. Omran said that before. The GBD study have expanded the concept of epitransition, and we can see population changes with more detail in the last 25 years of different levels, such as risk factors, age patterns, cause patterns, premature mortality and disability. In addition, the incorporation of social determinants in the GBD framework. For those reasons, I'm very excited to listen to the ideas of our distinguished speakers. The purpose of this session is to discuss trends in the epidemiological transition and what they mean for accelerating progress toward better health. First, let me introduce our presenter, Professor Theo. He's a faculty member of the Institute for Health Metrics and Evaluation and the University of Washington. He's a key member of the research team for landmark GBD study. As many of you know, he's the first author of some of the capstone GBD papers. Theo has a big experience doing national and global burden of disease, and also is part of the first generation of GBD makers. After Professor Bo's talk, we are going to have 3 splendid discussants. Following the order of the program, let me introduce Thomas Bollyky. He's a senior fellow for the Global Health Economy and Development at the Council on Foreign Relations. He's also an adjunct professor of law in the Georgetown University, and he has a vast experience in health policy. After him, Dr. Isabella Maina, a public health specialist working with the Kenya Minister of Health. Dr. Maina currently heads the Health Sector Monitoring and Evaluation Unit. She's responsible for coordinating the synthesis of necessary data and information to the health sector. It is very good to have in a session the presence of a policymaker to tell us how things happen in a country. And last but not least, Yohannes Kinfu. He is a demographer and economist by training and specialized in global health. Currently, he's a senior fellow and leader of the research group of the Burden of Disease and Health Resources at the University of Canberra, Australia. To finalize the introduction of our speakers, I would like to highlight the contribution of Yohannes as GBD collaborator. Thanks to him, to his work and his persistency, we have new important assets in the GBD framework. His contribution was to persuade the core team to incorporate the social demographic indicator, better known as SDI, in the GBD analysis. Always good arguments are very welcome. Thanks, Yohannes. You did a great job. Professor Voss, you have the floor.
Thank you, Rafael. 23 years ago, I just started a job at the London School of Hygiene and Tropical Medicine and was asked, can you take on this project in Mauritius? I said, I don't care what it is, that sounds all right. You'll have to report to this guy in Harvard called Chris Murray. Unfortunately, at the time, nothing was yet written about the methods of burden of disease. But I was told, don't worry, Catherine Michaud from Harvard will come along with you and you'll be fine. And here we are now, where we have an edition of The Lancet of 400 pages and probably way more than 10,000 pages of appendices that go with these papers. One of the threads in the GBD 2016 series of papers is the relationship between health outcomes, burden of disease, and development. Now, for the few of you who haven't yet gotten to page 400 of The Lancet, I'm going to show you quite a few of the illustrations that we have been using in these papers and show you different ways in which you can explore the relationship between development and health outcomes. It starts with the concept of demographic transition, where in the box marked as 1 is the pre-industrial area where most countries or all countries have moved out of. You have high mortality, you have very high fertility, but relatively stable population. Then mortality starts to drop rather fast with a lag of a drop in fertility and an explosion in population numbers. Towards the latter half of the graph, where you see a stabilizing at low levels of mortality and fertility, and some countries are at a point where their population numbers are dropping unless it is supplemented by new incoming migrants. Now, the demographic transition is strongly linked to development. And since GBD 2015, we've been using this indicator that combines a measure of income per capita, average years of schooling in the population over the age of 15, and the total fertility rate. And we cobble them together like the Human Development Index is created as well. And we then have grouped countries based on their current status on the SDI into 5 different quintiles. So let me show you a number of things that you can observe. First, on just all-cause mortality rates. This is by these 5 groupings of countries from low to high socio-demographic development. And you can see a steady decline in each of the 5 quintiles. This is for females, similar sort of pattern in males. But if you look at it in absolute terms, it looks like there's a convergence of these mortality rates. But if you look at it in relative terms, and those are the numbers relative to the 1 value at the bottom curve for high SDI, you can see actually there is a widening in relative terms of the gap between those at lower levels of development and those at the highest level of development. Another way of looking at it, this is plotting life expectancy at birth over the period 1970 to 2016 for all the GBD locations. Hence, it looks more like a modern painting. And on the x-axis, you see the SDI. And you can see in both males and females, this very strong relationship between the level of SDI and life expectancy. The coloring is for different time periods, so you can see how this has progressed over time. So, linked to this demographic transition is the epidemiological transition. And as the childhood, or in general mortality, but largely childhood mortality rates decline, fertility drops, this causes that make up the burden of disease start to shift from those of communicable maternal, neonatal, and nutritional deficiency origin to non-communicable diseases. And SDI is a strong predictor of that transition. Injuries follow some pattern, but it follows its own sort of pattern along the development continuum. So these are what we initially called our triptychs, but then we rearranged them and they became pentatics, if that word exists. And I'll take you through a few of these. So we're starting here with the years of life lost as age-standardized rates. And each of the panels is one of the quintiles of SDI, from low SDI on your left to high SDI on your right. In red, we have the communicable maternal neonatal nutritional causes. In blue, non-communicable disease, and in green, the injuries. Mark in the panel of low SDI in injuries that sometimes these injuries have an enormous spike. So the tallest spike there is actually the Rwanda genocide. But the overall picture here is that there's been a dramatic and fantastic drop, particularly in the rates of death and translated into years of life lost of communicable maternal, neonatal, and nutritional deficiency causes. But also a considerable but less dramatic drop in the rate of dying from non-communicable diseases. Injuries, some decline at most of the levels of SDI, but at a slower pace than what you see for these other groupings. However, if you look at these in absolute numbers, then you see what the effect is of population increases and a change in the age composition of populations. So instead of a steady decline in the rates of NCD YLLs, you see it creeping up just because there are so many more older people and they have a greater risk of dying from non-communicable diseases. In contrast, when we look at our non-fatal estimates, well, the first thing to note is how much more uncertain we are about our YLDs, and that is partly the difficulty of dealing with sparse and heterogeneous data on prevalence and incidence, but it is to a large extent also the uncertainty about our disability weights that is translated into this large amount of uncertainty. Here you see on the rates of YLDs that there hasn't been much shift in those rates for the non-communicable diseases. Some decline in the disability from the communicable and maternal neonatal causes, and not that much of change in the rates either for injury consequences. Again, in absolute numbers, and this is important for people who have to plan health services, you see this very large increase in the number of YLDs, particularly for NCDs, and not just at high income or high SDI levels, but look at how steep the curves are at low, middle, and middle SDI. And then cobbling this together in DALYs, you can see that the pattern of the age standardized DALY rates closely follow that of the YLL rates, because that's still, in most parts of the world, the largest component of DALYs, how we measure burden of disease. And then again, the effect when you take into account all these numbers of people at different age groups, and hence the expectation that there will be a very large demand for health services that deal with the largely chronic non-communicable diseases. Another way of looking at this is the leading causes, and all you need to see here is what's blue is NCDs, what's red is the communicable maternal neonatal causes, and green are injuries. So you can see that there's been a shift down of all the red causes and a shift up in the blue non-communicable causes. If we look at this for low SDI quintile, you can see it's still dominated by the red causes, but already ischemic heart disease in 2016, even in low SDI countries, has floated to the top of the list of age standardized DALY rates. Whereas in high income, in 1990, there was still one red cause among the top 15 that dropped out, and you can see it's almost completely blue with a smattering of injury causes in the top 15 causes. Yet another way of looking at this. Here we're showing the level of SDI on the y-axis from 0 to its highest value. On the bulk of the graph towards your right, we're showing the YLLs, how they change over the spectrum of SDI with development, and towards the right, what the corresponding pattern is of YLD. So the big story here is the massive shift with development, particularly in YLL rates. And so there's massive success in reducing the major causes of mortality. A lot of the big areas at low levels of SDI are childhood causes that have been successfully addressed as countries move along this epidemiological transition. But far less change in the rates of disability. And that is important to note, as that will determine a lot of what the burden will be on health services to treat with the health needs of populations as they move through the epidemiological transition. A few other slides showing similar sort of things, but in a different way. So here we have SDI on the x-axis again. We flip-flop a little bit on that. And here it's showing the age-standardized DALY rates for the communicable maternal neonatal diseases. And here you can see it follows a pretty steady pattern relative to the black line, which is the prediction of the relationship between SDI and age-standardized DALYs for these causes. Most of the 21 regions closely follow that pattern, indicating SDI is a very big determinant of that shift with development to much lower rates of mortality. Big exception, that blue spike that you see there is southern sub-Saharan Africa, and that's largely due to the large HIV epidemic. For non-communicable diseases, yes, we also see this pattern that there's overall an expected decline in age-standardized DALY rates, but you see much more variation from region to region around that expected pattern. There are regions that do rather poorly on non-communicable diseases. Way at the top in purple, Oceania. So all the Pacific Island countries with their very large burden of diabetes and cardiovascular disease, for instance. You can also see the Russia and Eastern Europe enormous increase in non-communicable disease burden that happened around the breakup of the Soviet Union. You can also see the success stories that Richard Horton was talking about. Parts of the world that are doing much better than we would have expected for their level of development. And then for injuries, also a steady decline with development overall, but some large notable exceptions. And being able to highlight this information is gives us great insight of what happens at local areas rather than this general pattern with development. Just to finish up a few other ways of looking at this, this is a map that shows the proportion of DALYs that's due to YLDs in 1990. Very red color means a very low proportion of DALYs is due to YLDs, and the bluer or more purple you get, the higher the proportion is. And just shifting from 1990 to 2016, you can see the world has become a lot bluer, a lot more purple, and there are far less red parts of the world, but there are still parts of the world where it is largely mortality that is determining the burden. But it's shifting at every level of development towards greater amount of disability as opposed to mortality determining the burden. And then lastly, the magic of being able to look at what is expected based on level of SDI versus what we observe in the data. You can start looking at those who perform well and those who perform less well compared to what we would have expected based on development. Red is bad. Again, blue is very good. And that shows that there are big differences with the traditional picture of what you think about progress. You see countries in Africa that are blue, that have done far better than expected. Parts of the high-income world that have done quite well, but other parts of the high-income world that, relative to their level of development, are doing far worse. Just a few snapshots of all the information that we have and all the different ways in which we can provide the information and hopefully kindle the interest of people who make all these important decisions about how we spend resources on health. Thank you.
Thank you to Chris and IHME for inviting me. I'm thrilled to be here as part of the celebration of the phenomenal first 20 years of GPD. I've been asked to speak from a Washington insider and policy perspective. as to what the GBD shows us about the epidemiological transition and what it might mean for progress towards accelerating improvements more broadly in global health. In playing that part, I'm going to make 3 points. I'm going to read leads from 2 news articles. I'm going to compare Chris and Alan to a medieval French physician. And then I'm going to reference the 1967 movie, The Graduate, in describing the role that I see that IHME can play in accelerating better health around the world. The first point I'm going to make is that evidence-based policy is impossible without good data. But having good data doesn't ensure that evidence-based policy will ensue. To prove that point, I'm going to read the leads from 2 news articles. Here's the first, so bear with me. A major new international health study reverses the recent flood of warnings about infectious diseases and predicts the largest problems of the next quarter century are likely to be chronic conditions, especially those that now largely affect the elderly. What this means, say the authors of this study, is that governments are spending too many of their health dollars on diseases like AIDS and too few on mental illness, heart disease, and cancer. Here's the lead to the second article. A sharp decline in the deaths from malnutrition and infectious diseases like measles and tuberculosis have caused a shift in global mortality patterns over the past 20 years. According to a report published on Thursday, with far more of the world's population now living into old age and dying from diseases mostly associated with rich countries like cancer and heart disease. The first quote is from 1996, late 1996, and it is a wire service report about the first GBD released. The second quote is from a 2012 news article about the relaunched GBD. Both stories appeared in the New York Times, and it's remarkable how similar they are. The point is that while we have learned a lot, and as Alan described, there's been a lot more going into these estimates about the epidemiological transition in lower income countries, and the details matter a lot. The first GBD has held up pretty well in predicting the macro trends. It predicted that NCDs over the next 20 years would rise to 73% of all deaths, from 55% in 1990. We are at 72% now. So while I think there is a case for Chris and Alan to be referred to as the Nostradamus of global health, there you have your French physician, the donor spending has shifted little in response in between these 2 news reports. NCD funding has increased over that time, but as a share of overall development assistance in global health, it has actually gone down. In 1996, it was 1.5%. And in 2015, it's 1.3%. This brings me to my second point, that the history of GBD in reference to the epidemiological transition reveals that there is a divide. And that divide is between health actors that are fundamentally more interested in particular diseases and conditions, and health actors that are fundamentally more interested in particular places and the people that live there. There's a case to be made for both views. And I think GBD has an important role in working with both set of actors amid this epidemiological transition to push for broader improvements in global health. And this brings me to my third point in the movie The Graduate. For those of you who've seen this movie, the main character, Benjamin Braddock, is at a pool party. He's around 20 years old, and one of the friends of the family asked to offer one word of advice about his future, and that word was plastics. Well, on the occasion of IHME's 20th birthday, and as a friend and a collaborator of the institution, I want to offer one word of advice about the future, if I can be so bold, and that is micro-targeting. Now, perhaps like plastics, micro-targeting has gotten a bad rap, given how it was misused in the last election. But the term just means designing content around the particular needs and interests of the intended audience, and not relying on us, the policy community, to draw from the undifferentiated message put out there from consumption what is really important. And for health actors, I think, interested in the traditional diseases and conditions of poverty, either by worldview or by virtue of the terms of their institutional governance, I think GBD will continue to be important in helping those actors pursue those diseases in the hard-to-reach settings where they will remain important in the future. So the most recent, I think in the latest issue, there is a gorgeous example of this, the mapping of under 5 and neonatal mortality in Africa, which does this. I think there's more to be done in looking at fragile states and slums, disaggregating slums from urban settings about where infectious diseases and malnutrition will remain big problems, and how we can provide the evidentiary base for health service delivery in settings where global health as a community has largely not been very effective in, again, fragile states and slums. This is an area, the second area is national and local governments and bilateral donors that are fundamentally interested in particular places or populations. The future is providing subnational data to identify inequities, slicing that data in ways that reveal the best opportunities and reveal the broader consequences that might result from not seizing those opportunities and provide accountability for doing so. This is the area where I've been working with Chris and people like Joe Dielman and the rest of the great IHME team. In 2004, we released a task force report on NCDs that used GBD data to look at the 49 countries where the US invests $5 million or more in global health aid. We sliced that data to look at population 59 and younger, and we did a preliminary rough estimate of the potential lives that could be saved by focusing on those diseases in that population, in those communities. And our top recommendation that came out of that was hypertension control. And we had that for a particular set of countries, and again, particular population, and that has contributed and did contribute to some of the policy development that has been behind some of the initiatives recently announced in this space. So I think there's a lot more that GBD can do in this space. I look forward to my role in collaborating on it, and I congratulate again IHME and Chris on all that they've accomplished.
Okay, thank you for the invitation. I talk for Africa, for the low and middle income countries, and I'll focus more on what the epidemiological transition means, especially at the policy level for the African nations. We've seen that for the low and the middle income countries, we have sort of a double tragedy, and in some countries we actually have a triple tragedy. From where I come from, that is Kenya, we have NCDs, the communicable conditions, the injuries as a burden of disease for our country. So what does this mean overall for Africa? It calls for a complete policy shift. For a long time, we've been tackling communicable conditions. Our policies, our strategies have been by and large on communicable conditions. But right now, because of what we've seen even earlier, we need to focus on the NCDs and the injuries. And I'll give an example. In 2014, we did our health policy, for example, and we looked at the data that existed. And from the GBD estimate, we saw that injuries was a major component of the burden of disease in the country. And right now, our policy is focusing on 3 areas: injuries, NCDs, and of course, the communicable conditions, because it's still a major cause of burden for the African nations. So as we talk of policy shifts, more specifically, I think for me, it calls about for health, complete health system strengthening. Because as I've said, because of focusing on communicable conditions, our health inputs, mainly like the HR, the finance, the commodities, mainly deal on the communicable conditions. So what this means is that we really now have to focus and make sure that we have inputs that are directing energies towards the NCDs and injuries. And when we look at Africa, the point of entry or the foundation for the health system is the primary healthcare facilities. And this is where we want to focus on. The other thing that has been said by and large is the issue of data. For us to make good policies, for us to make good strategies, for us to give good guidelines, we need complete, timely, accurate, quality data. For a long time, and even now in Africa, in most of the middle-income countries, data exists, but more often than not, is not data that is useful. More often than not, the data is mainly on routine information system. If you look at what happens at the community events, for example, the births and deaths, we really do not have data that is of good quality. So I think as we need to bring the world to refocus, even on our regions, for data that will help us improve on our system, especially the community-based data. Apart from availability of data, improving capacity for us to be able to transform the data to information, to decision, to action, and to implementation, and of course, the issue of monitoring that. We've seen that by and large, there is increase in YLDs. What does that mean? If you take, for example, the issue of HIV/AIDS, more and more people are surviving. Yeah, it's no longer an issue of access. I think now the focus should be on the quality of care. What kind of quality of care are we giving to our clients? Especially now that we are focusing more on the disease for the elderly and all that. So we need to refocus our staff, train them to give more quality care, ensure that we have the necessary commodities, ensure that we have the necessary equipment. There was a study that was done in Kenya by IHME on some bottlenecks. And if we looked at, okay, the study, the people who did the study looked at availability of commodities for communicable and uncommunicable conditions, or even facilities that are offering the services. It was found that by and large, facilities do offer services, but when you look at the capacity to offer those services was really wanting. And more, the capacity to offer the NCD services. So I think for us in Africa, and more the low and middle income countries, we need to look at the capacity as we focus on offering quality services to our client. Something that is not often said is the soft inputs, the issue of leadership and management. Yeah, we have the data, we have all this information, we know that we should do good policies, we know that we should have the policy shift from maybe communicable, or mix of communicable NCDs and injuries, but as long as we do not have good leadership at all levels of the health system, this will not work. And I think the first panelist talked about political leadership. Politics is also very important in health. It's the gel that holds us together. I think if we do not involve the politicians, I think we'll not get there. And what it means is that we have to break down, for example, the presentation that I have done in a language that the politicians understand, because they're the people who will give us resources. They're the people, especially from where we come from, they're the people who determine, they're a major part of the policy-making process in the country. So as we involve stakeholders, let's also consider how we involve the politicians. We bring the politicians on board. And of course, the global efforts, global community. Yeah, there's a lot of focus on SDGs. I think we've really not mapped out the action plan of how we are going to implement this. Yeah? As much as at the global level we've said that these are the SDGs, we've seen the disparities in the globe, in the low SDI countries, in the middle SDI, and of course, the fully developed countries. And now we have these common targets. Will the roadmap be common? To me, maybe not. So I think we need to bring the global community together to see how we improve all these things. How do we come together to make sure that the health systems in this part of the world are able to respond to the challenges that exist right now? That the health system, we are focusing on a strong health system, that we are focusing on building the HR, we are focusing on ensuring that we have commodities that will address the issues that we have, or the burden that we have. We are talking about integration, and of course, involving other stakeholders other than the politicians, the global community, other stakeholders from other sectors like education. More importantly, I think as much as we are talking about the condition or the situation at the national level, it's good to focus at the sub-regional levels, yeah? Because we've seen that, yes, we have situations of the country, and we have seen the transition, if we talk, for example, the epidemiologic transition or the demographics transition, you could talk of the transition for a low SDI country, but when you go within the country, there are sub-regional disparities. So even as we talk of the policy shift, we should also have strategies for the different areas within a country. And I'm glad GBD has been able to give us sub-national estimates for the country. We are now fully devolved. Now I speak for Kenya. We are now fully devolved. We have 47 autonomous units that are responsible for resources, allocation of health resources to their regions. That would mean it's more important to break the information we have down for them, because they are responsible for allocation of resources for health in their respective sub-regions. So we are glad that from now, especially now that we are going into the next phase of planning, we'll be able to use the results for that. And I encourage other countries who have similar situation to look at the GBD data. It will help quite a lot. Thank you very much.
In my career, I focused on two areas. One is my interest around grassroots level development in health statistics. The other area, which is of interest to me, is knowledge generation. So my comment in this session will focus on those two areas. So I'll focus on the broader theoretical issues as well as on specific elements. Prior to the GBD exercise, we know that our knowledge of the epidemiological transition was more focused on two previous work. The Omran hypothesis is there, which actually tries to stipulate the movement from a high mortality and high disease burden to a low mortality and low disease burden situation. And of course, we have also the Princeton income hypothesis, which tries to relate income with mortality. So with this new exercise now, we've been able to prove that some of those hypotheses actually hold in many settings. Also from the policy perspective, for instance, we have looked at the movements of diseases and how they declined over time, particularly for HIV. And in addition to those, as Theo showed, instead of just focusing on overall trend and also the rate at which they declined, if you actually focus on look at the differences within the SDI categories, actually, although the absolute level has declined, the relative difference between high HDI countries and low SDI countries have actually expanded. So that is a pattern which was not captured before. And we were able to do so because we have this overall index called the socio-demographic index. And what makes it different from a previous exercise was that the previous was just more focused on mortality. Now we capture a broader set of factors. And what that means is also is that previously, countries like Sri Lanka or states like Kerala were considered as exceptions to the rule because we are more focused on income. And those countries were more advanced in terms of education and fertility and so on. So so capturing SDI have actually helped us, to understand the epidemiological transition much clearer. Another point that was raised by Theo was that actually if you look at the ratio of expected and also observed trend with respect to SDI, the pattern actually is more diverse. We see, this is the blue pattern even in areas where we did not expect, right? And I think that is also one area that we can do further analysis. For instance, Theo showed that, for instance, in some African countries, we saw some blue color, meaning doing better than we expect them to do. One area that we can, enrich our, understanding of those situations is, for instance, by expanding the SDI index to cover access to health care. That can be done by including UHC as part of the index, or some sorts of, controlling for social protection. So that's one area that we can do this further. Also, initially the Omran hypothesis assumed that, the epidemiological transition was a single path, that, you move from one particular, from high mortality, situation to a low mortality situation. But with more data, we understood that actually there could be some double burden, right? Some countries will have both, high communicable disease burden as well as also significant NCD burden. So that double burden is more clearer now. What does this mean? Actually, if we look even further, meaning if we look at subnational analysis, as it was mentioned by my colleagues earlier, we may be able to see more, of this diversity. The subnational analysis is not just, of academic, is not just of academic interest only. It has also policy relevance. And as I always say, statistics actually is important because marginalization is actually expressed in terms of statistics. Marginal people are actually marginalized also in a statistical sense. We don't know about them because we don't measure things about them. So the more we go to subnational analysis, we will be able to reveal some of this invisibility and also maybe that promote some action. But when you move to subnational analysis, there are challenges. The issue of data, measurement issues. Part of this comes because most of the data that we need for DALIs, as we move from communicable diseases to NCDs, that becomes sparse. We don't have much data on NCDs. But then there is a need to be innovative there. Maybe some parameterization, some model tables and things like that. But there is also another challenge when it comes to subnational analysis because we have to work with countries to get that data. And what will we do if countries are not interested in releasing that data? That means the issue of transparency. And that also brings challenge to the GBD enterprise. In a sense that to what extent will we remain gather, a requirement, which also includes, transparency. Finally, I just want to also share some experience in other countries where I had the opportunity to visit and work with. For instance, in Tonga, in the Pacific, they have actually embraced a model whereby nurses, which previously used to do family planning work, now do NCD work. So the success of the family planning exercise, which included data collection on, visits to households and things like that, is now used. The same procedure is now used to tackle NCD burden in that country. And that kind of data collection exercise can help in, getting more data for this exercise. Thank you. I will stop here.
Okay, thank you. Thank you very much for these very good presentations. We have some time for questions and answers. Just let me raise 2 points, and for me are key in this discussion. First, as Dr. Maina showed to us, we have very good results that show us the health needs for the 21st century. However, we have a health system in several countries for the 20th century. So what we can do? Richard Horton was asking us, go more with the politicians. Dr. Maina was telling us, go more with the politicians. How we can fit that? It is we continue talking about health needs, problems, more problems, and also we need to raise the idea of solutions. And the other point is the subnational. It is, in my experience working in Mexico, when I presented the national, someone raised a hand in the room and said, where are you going to have by state? In Mexico, we have 32 states. And next year, we presented the results by state, and someone raised a hand. When are you going to have this by county, by municipality? So these things never end. Because as someone says before, public health happens at the local level, and that's where they need the information. National is for global agencies, but local is the most important. So thank you very much for all your presentations, and we have some time for questions and comments. It's hard for here with the light to see who is asking for the micro. So please help up. So your name, please, and be precise with your question.
Okay, I'm David Cundiff, independent researcher from Los Angeles. And my question relates to one of Dr. Voss's slides. In the lowest SDI quintile, ischemic heart disease was the highest cause of loss of life. And all the rest were blue or red. And I looked into the relationship of SDI with ischemic heart disease a bit and the risk factors. In the lowest SDI, there's the most plant-based diet compared to wealthier quintiles. And so the serum cholesterol is the lowest, but the blood pressure is the highest. And in higher quintiles, ischemic heart disease loss of life is plummeting. And in the lowest, it's increasing or at least not dropping. And I wonder if any of you have some ideas about what seems to be a paradox.
Thank you for that question. I think that may be an overgeneralization that the diets are still largely plant-based. There's a big shift, even in low-income countries, where there's been development, where there's a greater proportion of people who have access to other types of food and are shifting away from this largely plant-based diet towards a much higher intake of animal meat and animal fat. And so I think it's partly that these patterns are changing, and partly it is also the demographic shifts. When you have an aging population, which even at low SDI you see that already developing, you see many more people coming to ages where ischemic heart disease is an important cause of death. And as many of these countries are not prepared with their health services to deal with the consequences of ischemic heart disease, you will see very high case fatality for people who develop the disease.
Thank you. I saw, I see, yes, please, behind. Or who is the micro? Okay. Go ahead.
Good morning. I'm Kumaran Rasanathan from UNICEF and thanks for the presentation. It's a pleasure to be here. Theo, I really like your slide which shows the SDI index compared to outcomes and shows that variation so that income's not destiny. And yet both Tom and Isabella have sort of touched on the challenges of translating this data to political action. So I wondered, particularly Tom and Isabella, you said you don't have the action plan to translate the GBD into political action. So what are we doing wrong? What can global actors and institutions do more to help translate this progress in data to better political decision making?
You think?
Sure. Great question. Thank you for it. I heard bits and pieces. There's a bit of an echo in here, so forgive me if I didn't get all the details. But as I understand it, the question was, how do we translate this into action? How do we break it down for policymakers? And I think it is through trying to. I think historically the GBD and Chris have been reluctant to do advocacy with this data because the minute you take an advocacy position, people question your underlying results. And I think there's a middle ground to be had there, where presenting the data on the population groups in the countries and in the terms that the particular audience you're looking at can understand. So I gave that example of the NCD task force just because this collaboration we had done with IHME, and Chris was exceedingly generous, and we had 2 staff people work on it fairly extensively. And it was on the metrics that the policymakers we spoke to, and I think we spoke to, I don't know, something in the area of 40 different congressional offices, every federal agency, most international institutions around this. You know, for some of them, it was presented in terms that they could understand. And that's what contributed, I think, to, or as I understand it, to some of the progress we're seeing in that space. And you can see that in other areas as well, where if you can present it in the terms, in the populations that are, the reason why it mattered in the NCD case is because it's working age populations under 59. It seems younger than what most people look at. We focused only on the countries, primarily on the countries that you had these investments. And for countries that are invested in populations in particular places and their economic and health well-being in the future, that's really relevant. And I think you can do that in other areas as well. So that would be my recommendation.
Thank you, Thomas. Yohannes, please.
Okay, just a couple of points here. One, I think actually the GBD results have made big difference already. And as Richard indicated earlier, you know, NCD is now on the map, right? And it is part of the SDG. So it's already, you know, making a difference. We also know that the role of, or the contribution of GBD with respect to MDG monitoring. That's also another area where the results have been translated to action. But that doesn't mean that, you know, you know, there is no more work that is not that is needed. As we know, politicians have national mandates, right? So, you know, and also their actions is often restricted within their national boundaries. But GBD so far has been focusing on national estimates, not subnational estimates. So when we move toward subnational estimates, I expect to see, you know, more of these being used in national debates and actions. So more yet to come, I think.
Thank you. Theo, please.
Yeah, just also some reflections on this. And having studied the banner behind us from you know, the early start of GBD as a vulnerable premature baby needing kangaroo care by the mother, we're now a pretty healthy adolescent, I would say. And over the time period that I've been involved in this work, I think we have made major advances in making the information more accessible and making it more attractive for people to pick up. Very important was getting the credibility. That I think we've moved from some people who were making some rogue new types of estimates that most people were skeptical about in the public health world, to being the place to go to when you want to get reliable data on health in the world. I think that was essential. Having that reputation, we then started to produce all this information in much more attractive ways than we've done in the past. And all the magic online visualization tools, but also these initiatives with policymakers to present things in a way that, that can more easily be picked up. But I think our role goes to, there's a limit to what we can do. We have to rely on you as our collaborators to pick up the dialogue with policymakers on the results that are most important in your countries or in your area of work. And we'll probably need to explore greater ways of disseminating information. But I think our role is to supply you with the ammunition to be able to have that dialogue with the relevant policy people.
Thank you, Theo. I'm afraid we have to... One more question. Okay, I tried to make
Thank you very
easy.
much. Howard Hu from the University of Toronto. I'm going to first say thanks for this forum, but pose a question as a challenge to the GBD leadership. What I've heard today was a lot of interest in getting more of this, and with the last question in front of the politicians, but the focus when the discussion has been on policy has all been about health policy, that is healthcare and public health. And the reality is, as the health and all policies movement has demonstrated, is that so much of what will influence the non-communicable disease burden of the future is policy that is not related to health. It relates to transportation, it relates to land use and how we site our cities and promote walkability, agricultural subsidies and how we have subsidized industries that have produced processed food and high glycemic index foods for mass consumption, transportation use, where we site polluting industries. And I think that the global burden of disease has amassed the capability of looking at how we might actually look at how different policies may affect health. And that's a challenge, I think, that was embedded in the remarks made by our Lancet editor today. And I'd like to hear how the global burden of disease leadership might view these kinds of challenges as a research question that might drive policy-relevant investigations for the future.
Well, I think he wants it from the leadership.
So we pass to...
Maybe by proxy for the leadership. I think these are very pertinent issues that you raise. And maybe what I can say is when we talk about health policy, we tend to think of it more broadly than just policy being made by ministers of health. Because there are lots of things that impinge on health, as you indicate, that require action that goes well beyond what a Ministry of Health can do. How much can we do? I think we are very open to working with people in different fields. And I must say, over recent years, there have been some very interesting overtures from people in areas where we had not expected any great interest in our work. And I think we need to foster relationships with people who come from very different disciplines and look at how we can together influence policies that go beyond what we tend to think of as more immediate health policy areas.
Okay, so let me give last remarks, if you allow me. First of all, I'm sure that GBD should make visible the invisible, which means raise points and always are out of the programs of health or from the politicians. What I mean are those diseases that are more related with disability than only AIDS. Second, we have to take advantage of the visualization. Visualization in the real world empower everyone. Just because you get information that is right and information that is accessible any moment. It's better to have our own story than the story of someone else. When we can build that story by our own knowledge, it is much better. And finally, I believe that we have to continue pushing in the direction of the policy dialogue. We have different audiences. We have researchers, we have students, journalists, politicians at the high level, and we have to think in the health system is not responsible for all health. It's responsible for something that can handle, but there are a lot of intersectorial relations that we have to keep moving, and the visualization and the burden of disease is a very powerful tool. Thank you very much for your attention, and we will keep with the program. Congratulations.